we did the pituitary topic, and the other area my residents are a little bit uncomfortable is temporal bone. And that's the reason I picked two topics which were slightly complex or subtle, and just wanted to elaborate on that one. Before I start this session, I just want to get an idea about what you practice so that I know how much to stress on different levels. So I just want a hands up on kind of how many of you do temporal bone CTs, read temporal bone CTs? So majority of them. So, and also, how many of you read at least 5 temporal bone CTs per day? I think now I get a fair idea. Like maybe one at least a day. Okay, that's great. So that gives me a sense of where to set my, like what things to stress on and things like that. So malformations of the temporal bone is the normal anatomy of the temporal bone itself is complex, and malformation can be even more difficult. So just bear with me. And what I did was I kind of split this topic because whenever I give this talk, like at least 2 residents fall asleep. So I just don't want that to happen. So I'm going to give a break. Okay. And just to start off, just a normal anatomy, I just want you to comment on, pick up the findings, just to kind of start off. There's really not tough things. So comment, what are these 2 structures? This is just to bring the speed to the, like the talk to the rhythm. Superior semicircular canals. What is this one here? Sorry? Correct. Or subarcuate canal, or petromenstrual canal, all the same. Right? And, okay, so what is this one here? Right, yeah. And this is the vestibule, and that's the lateral semicircular canal. Right? And what is this septum here? Sorry? Corner septum, yeah. This is just to quickly go through the anatomy. It's not to have any session. What segment is this? This one is. Sorry? Right. And then this is the vestibule. What is this one? Sorry? Singular canal, right? Singular canal. It's the superior vestibular nerve canal. That's right. Right. Okay. So these are axial cuts. These are the cuts which you really pay attention to. The actual talk is later. This is just to get you into the talk, because many a times this is what I've noticed. Whenever I've given this temporal bone talk, like I lose connection. So that's why I'm just trying to involve you. And that's a cochlear aperture. What is this one here? Correct. So it's a canal for the inferior vestibular nerve, right? Okay. So I think the things came up. So I wanted to ask you. This is why the other thing, a lot of residents don't recognize this structure. That's the cochlear aqueduct. We are always familiar with the vestibular aqueduct. There is another thing called cochlear aqueduct, which kind of mimics the morphology of the internal auditory canal, and it can look like a cochlear aqueduct. And so the cochlear aqueduct can look like a internal auditory canal. This is a coronal image. Facial nerves there. You're cutting through the cochlea. That's the ossicular chain. The facial nerve at the oval window. That's the oval window. That's the stapes going into the oval window. Vestibule, semicircular canals. That's the basal turn of the cochlea. What is this? Correct. Crista falciformis. That's very nice. There are 2 bony structures that's the horizontal thing which you're seeing. What's the vertical thing called? Feldspar. That's right. What is the arrow pointing to? No. So, well, what's that? Round window, yeah, it's a round window, right? So round window, most of us are familiar with round window, seeing it on an axial cut. The basal turn, you'll see the round window niche. But this is actually a very useful plane for the round window. On a coronal image, you see the vestibule, and the vestibule should flow into the open into the middle ear. There is a thin membrane here, just a membrane. This is a sagittal image, the ossicular chain. And what is that arrow pointing to? Or what is that arrow in trying to show? What is that structure which goes in that pathway? Sorry? You're right. What is it? Cauda nerve. So that's the facial nerve, and it goes through it's a branch of the facial nerve. It goes through the middle ear. It goes through in between this is the malleus and this is the incus, and it goes between the incus and malleus and enters, what is that? That's a fissure for the cauda equina nerve, and it enters the posterior margin of the temporomandibular joint. Okay, so that was just to kind of get you all involved. So in external, when you assess a CT of the temporal bones, I always start either from the lateral aspect going medially or medial to lateral, and evaluate individual structures. Like say, I'm starting off laterally, external ear, I scroll through all the external ear and come back. Then go through the external auditory canal, scroll through it, come back. Don't look at the imaging plane. Don't look at it as an image and then assess the individual things. You go lateral to medial or medial to lateral, your choice. But you have to scroll through that whole structure, assess it, and then go to the next structure, scroll through it completely, and go one structure at a time. So on this talk, what I did was I went lateral to medial. So I'm talking about external ear anomalies. When I talk about external ear anomalies, it could be anomalies of the pinna or the external auditory canal, where the primary abnormality or the most common or important abnormality is the atresia of the external auditory canal. And I wanted to include these other two things. One is the first branchial cleft cyst and the foramen tympanicum. Those are, this is kind of, it occurs in that area, even though it is not exactly related to this, so I included that one. This is a common finding I just wanted to be familiar with as well. So external auditory canal atresia, so as the name suggests, this is a schematic picture. That's the pinna, which is kind of small, deformed. Actually, it's not showing it very well. But you see this bony, thick plate. Instead of having a external auditory canal here, there's a bony plate. That's the ossicular chain. You have other degrees of external auditory canal atresia. The subtle one is where you have just a stenosis, just slight narrowing of the external auditory canal. The other one is somewhere in between these two, where there is an attempted formation of the external auditory canal, but there is an atretic plate. One word about this kind of very subtle form, where you're assessing, I'm sure your protocol is just you have a right T-bone and a left T-bone. And if you don't really look at the external auditory canal side by side, you will miss the subtle stenosis of the external auditory canal because you're not comparing it. Otherwise, it's so subtle. The subtle narrowing of the external auditory canal is missed usually. So I want you to really scroll. If you're suspecting external auditory canal atresia or stenosis, you compare it side by side and comment on that. So let's focus on this one now. So tell me one thing. Do you have a pattern, or do you follow a scoring system, or do you talk to your ENT surgeons? Sorry. So ENT surgeons, they elect to either repair or put a BAHA device. BAHA is a bone-anchored hearing aid device. So their clinical judgment whether to do an atresioplasty, to drill through the bone and reconstruct the external auditory canal versus just put a BAHA device depends on a scoring system. You need to, basically you can follow any scoring system, but you have to be consistent, or you need to know your surgeons and they need to say, okay, this is what we follow. I want you to give me the scoring based on this criteria. So it doesn't have to be this scoring system. There are various other scoring systems. But I just wanted to let you know that there is a scoring system, and we have to report our CT temporal bone in any patients with external auditory canal based on the scoring system. So this is the scoring system which I use, and I don't give a score to the T-ball. I never do that. I don't say this is a score 10 external canal atresia. I always describe the findings. I'll let the surgeons score it because they have other things to look into it. So the scoring system, I just want you to notice, read about the structures which you're going to assess. Notice this, the maximum score achievable is 10, and the stapes bone has got a score of 2. That indicates the stapes bone morphology is such an important thing when you comment on external auditory canal atresia. And rest everything is score 1s, but I want you to notice how the things are structured. Actually, this is not the order in which it is in the literature. In the actual literature, it is not in the, I don't know why they did that, the way they did it, but I kind of reordered it in such a way that it is easier to understand and easier to remember. So here, stapes bone, incudostapedial junction, and malleus incus morphology. Basically, it indicates everything in the ossicular chain. Incus, malleus, stapes, and the stapes bone itself, the morphology. And then there are 2 windows, oval window, round window morphology. Is it stenotic? Is it open? Is it normal morphology as well? Oval and round window. Then you have pneumatization here, mastoid. Is the mastoid process well formed or not? And is the middle ear well formed or not? But both are, technically it's all the same. It's the pneumatization of the middle ear and mastoid. Then you have facial nerve morphology. The canal is, how is the facial nerve going through its normal course? And then the external ear morphology, which is auditory canal atresia, and also the pinna. Is it normal or not? So let's quickly go through a few images. So I mentioned on this one, I just said the maximum achievable score is 10. And every normal structure, if stapes is normal, you score it as 2. If it is abnormal, that will be a score 0. That's how you score it, right? And if the patient gets a score more than 7, that means more normal structures, then surgeons go in for atresioplasty. If the malformation is more severe and more number of structures are abnormal, then the patient will receive a score of less than 7, and they will go for Baha device. Does it make sense? Right. So let's go through a few things. It's in that order. And to make it easier to understand, what I did was I put all the normals on the left side and the corresponding abnormalities on the right side. So let me show the normal first and then explain the abnormal findings, so that way it's easier to understand. So here, notice the external auditory canal is present. The left external auditory canal is missing, right? Then you have the ossicular chain, that's a stapes entering the oval window, and you have the facial nerve, the semicircular canals, and the basal turn of the cochlea. What's happening on the left side? The external auditory canal is missing. Not only that, notice the volume of the middle ear, the aerated portion of the middle ear. It is smaller. The craniocaudal dimension is smaller. And these are 2 different patients, so I'm not trying to compare this to this, but I'm trying to say, notice how the tegmen tympani is at the same level of the superior semicircular canal. It goes flat. There is no dropping of this height of the tegmen tympani. On this patient, the superior semicircular canal is at a higher level than the tegmen tympani. That means basically the tegmen tympani is lower and the volume of the middle ear is smaller. What else is happening? That is you're not seeing the complete incus malleus. I've got a next slide, but here the incus and malleus is adherent to the lateral wall. That's not okay. And also, if you notice here, the incus and the stapes, the junction is always a 90 degree. It's a 90 degree curve there. It always should be 90 degree or slightly less, up to 80 degree, but it should never be 90 and above. Like it should not be 100 or something like that. So what's happening here on this one? The incus malleus complex is attached, and the stapes is approaching the round oval window in an oblique fashion. It's an obtuse angle there. Does it make sense there? It goes straight here. And the facial nerve is hanging onto the oval window. That's an abnormal finding. Let's go here. This one, this is to show the round window. So that's a normal round window. That's the vestibule, and the round window should flow open into the middle ear seamlessly. Whereas on the left side, there is an atretic plate. And many times the atretic plate covering the round window may not be that thick. It could be a thin membrane, but you need to look for the atresia or a plate on the round window. And also mastoid pneumatization here. So it's the same thing, it's a combination. If the middle ear is smaller, even the mastoids are smaller. But if the mastoid is smaller, middle ear can be normal. The association is not strong both ways. So if the middle ear is smaller, I always pay attention to the mastoid pneumatization. That's a mastoid process which is normally pneumatized. The left side, the mastoid is small, hypoplastic. That also makes the temporomandibular joint to lift up a little bit, and you will see the head of the condyle of the mandible higher at a higher level than the right side. External ear, so that could be microtia, which is actually a small sized ear, or it could be tags, pretracheal tags in front of the trachea there, or it could be complete anotia, the complete absence of the external ear like in this patient here. I always suggest, get the 3Ds of your external ear, the skin rendering. It's always useful. The clinicians, they see their pinna. You don't have to tell them the pinna deformed because they can see it. But if you don't mention it, it looks bad on our part. So it's for completion's sake, but I always suggest it's just like one click for the technicians just to add a 3D reconstruction. The reason is, look at this one here. This is the same patient as in this image here. Notice if I did not provide this image and if I did not give you the history, this almost looks normal. Only when you compare it to the normal ear than it is, you can make out the abnormality better. So I want you to reconstruct, and this is my protocol. I always tell them, not a standard protocol, I always call the text, I want the skin rendering. And they give me these two pictures, one from the right projection, left projection. So I can really compare both the pinna. So always ask for skin rendering. Microtia. So that's about the external artery canal and the scoring. And the malformations of the pinna could be either isolated or it could be part of various syndromes. So main thing what I want you to think of is when you see a pinna malformation, it indicates the external ear is abnormal, this patient can have conductive hearing loss, and we need to look for the external artery canal and the middle ear structures. That's what it means. So we are switching gears and going to the first branchial cleft cyst, and I included this here because it occurs very close to the external auditory canal. The second and third branchial cleft cysts are much lower. I didn't want to talk about it. So here on the image this is a sagittal post-contrast CT. You can actually see a well-defined cyst, which is kind of deforming or compressing the cartilaginous portion of the external auditory canal. And on the coronal image, you can see the cyst along the external auditory canal, the cartilaginous portion. This is a type 1 branchial cleft cyst. Type 2 is lower, and it's within the parotid usually, something like that. When you see a cyst in and around the external auditory canal, the things which you look for is any sinus tracts going deeper, and also is there any secondary signs of infection? Because many a times these patients present with secondary infection. And if you see, okay, so here's the thing. When you see a periauricular abscess or a infection, you look for underlying cyst, because sometimes the pockets of abscess can mimic a cyst, or the cyst can mimic pockets of abscesses. So one, either you look for an underlying cyst or a malformation, or ask the ENT physician to do an antibiotic trial and then get the patient back so that the infection subsides and you will see the cyst better. What is this anomaly? So this is, let me explain. This is a very tightly cropped image. Apologize for that one. This is an axial image, temporomandibular joint. That's a condyle. That's the external auditory canal. That's a carotid canal, jugular bulb. And there is a defect here. The arrow is pointing towards the defect. What is it called? It's foramen tympanicum. It's a fairly common anomaly. It's almost like 2 to 3% of normal population. You always see it. It's very common, to an extent that sometimes I don't even mention it in the report. You just see it. But the significance of this one is these patients sometimes, if you notice here, this is the temporomandibular joint, and the synovium is here. Sometimes synovium is itself is the wall of that septa, and it can break, and the synovial fluid can leak into the external auditory canal, and present as clear fluid draining through your external auditory canal. And these things present during the time of chewing and eating hard substance. That's how they're present. And you need to be aware of this entity, because sometimes the clinicians will be completely on a wrong track, where they're investigating for all sorts of CSF otorrhea, where in fact it is actually just a synovial fluid draining through the thing. So if you don't have an answer for CSF, if a patient is being evaluated for CSF otorrhea and you don't have an answer, if the mastards are very clean, middle ear is all clean, and if you see this, you question it. But it's a very rare find. Yeah, it's almost like a higher 5% incidental finding. So let's switch gears. And so we finished the external ear malformations, and we are going to the middle ear malformations. Middle ear malformations mainly are ossicular chain dysplasias, ossicular chain fixation, and oval window or round window atresias. Both are, I included that in the middle ear because they present with conductive hearing loss. And I just included this congenital cholesteatoma there because technically not a malformation, but I wanted you to be aware of the findings on this one. Okay. So I had to include this normal anatomy here so that you need to correlate the normal anatomy to the CT anatomy. So just to give you a sense of the size of the ossicular chain, it's a very small structure, and you need to really get high resolution sub-millimeter thin slices to get the anatomy better, especially the stapes. So here's a schematic picture of the ossicular chain. You have the malleus here, head of the malleus, and you have three processes. The largest one is the manubrium. The manubrium is the one which goes along the tympanic membrane. It's like it goes through the membrane. And then the other anterior and lateral processes are like a tripod. It stabilizes the manubrium against the tympanic membrane, right? And you have the head of the malleus, and the head of the malleus articulates with the incus. And the incus has a short process, which acts like a counterweight to the head of the malleus. That's how it balances the ossicular chain. If you have a dysplastic or a small short process, then the head of the malleus is overweight, and the motion of the ossicular chain is in an imbalanced status. So you have this short process which balances the head, and then you have a long process which goes down and takes a 90-degree bend, which I showed you on the thing. And then it articulates with the stapes. Stapes is a foot plate, and to crura. And you have a central opening. Does anyone know what the opening called? What do you call that central opening? That's the obturator foramen. Obturator foramen. Do you know of any structure which passes through that structure hole? Sorry? No, chorotympani goes through this space here. My arrow. It goes between the stapedial artery. Yeah, stapedial artery. If it is present, it goes through the obturator foramen, and it disappears. Right. So let's go through the anatomy. So what I did was I took the same picture and I tilted it. That's how you see it on the CT. The slices go in that fashion. So this is an axial image going through the incus malleus complex, and that's the slice. You have on this slice, this image kind of looks like an ice cream on a cone, right? So ice cream on a cone, and that's the ice cream head of the malleus. That's a cone. And one slice below, the section goes through the manubrium of the malleus, and then the long process of the incus. So that's the manubrium. That's the long process of the incus. And those two processes should be parallel to each other. They should not be in an oblique fashion. So they should be parallel. And you may have to scroll through it to get a sense of that parallel configuration. You can make that decision on just one image. Oh, I see this a little bit off, so it's most probably abnormal. Don't do that. Just scroll through it and get a feel for the anatomy of the malleus and incus. That's the round window niche I was talking about. So round window, we are used to see this in this fashion, the basal turn, and then you have the round window, and that's a round window niche. But I want you to be familiar with the other coronal image also, which I showed already. This is a section slightly lower than the previous section here, which goes through the stapes. That's the crura of the stapes, foot plate. So you see the stapes there, very subtle. Especially in pediatric age group, sometimes it's very difficult to see the stapes because it's not mineralized, so it could be cartilaginous. You may not even see it. But if you get an adequately thin slice and window it correctly, you will see it always, and if you are in the right plane. These are very small structures, so you need to be careful, slow, and take your time to interpret all the findings, right? Okay, so now, this I've already mentioned this to you, but this is an image, a coronal image going through the stapes. The slice goes this way. I've already spoken to you about the angle, the incus stapes, 90 degrees, and it should be 90 or less. If it is obtuse, the fulcrum is not adequate. It's not able to push in all the sound waves. It's not able to amplify the sound impulses. So you need to have that 90-degree curve. And then as you approach, so if you're in the right true coronal plane to the stapes, the slice goes through this portion of the stapes and then you hit the obturator foramen. So it as though it looks you don't have anything going to the oval window because that's the obturator foramen. So if you see a structure going through and through all the way to the oval window, then it is abnormal, right? But that indicates it's a stapes which does not have an obturator foramen. So always make sure that you have a gap in the true coronal plane. So 90-degree stapes and some lucency just before it hits the oval window. But make sure that you are in the right plane. Don't overcall it because sometimes the section can go through this limb and then through one of the crura. So make sure that you're not on that oblique plane, but if you're on the true plane. This is a section which is in a sagittal plane, and it looks, on this image, it looks like a molar tooth. That's a malleus, that's a manubrium of the malleus, that's a incus, and that's the lung process of the incus. That's the molar, it kind of looks like a molar tooth. So just to make it easier for the first year resident, this is what I tell them. Like, I've already told you all the other subtleties, but 3 images, 3 planes, 3 images. So it should look like an ice cream cone on the axial, and that's how you assess the incus malleus complex. Then on the sagittal, it should look like a molar tooth, and on a coronal image, it should have a 90-degree. Right? That's the easiest way I can really show the first year, second year residents. That's what I tell them because it's very T-bone anatomy can be tough. Okay. So now you tell me what's the abnormality. Sorry? Correct. It's an incudostapedial angle is obtuse. This angle is irregular. And also what else is happening? You're seeing the stapes as a straight line going all the way to the entrance, the oval window. So that's a dysmorphic stapes with an abnormally enlarged incudostapedial angle. Right? So just to give you a sense, so that's a normal, that's abnormal. What's going on here? Sorry. You're not seeing the, I did not hear you well. Correct. So this is an axial image. That's the supposed to be the ice cream cone. You're not seeing the ice cream cone is melted off and it is attached to the anterior wall. And on the sagittal image, it is attached to the anterior wall here and the superior wall here, which is the tegment tympani. And also, I mentioned that the manubrium and the long process of the incus should be parallel. You're not seeing that configuration. So your molar tooth is absent on the sagittal image. Your ice cream cone is not okay. So that's an abnormal ossicular chain. So that's normal for your comparison. Ice cream cone and a molar tooth, that's both missing, right? So I already talked briefly about this. This is the stapes, and you should have an air lucency, which is the obturator foramen. If that is missing, then the stapes can look like that, like a straight line. It's called a monopod stapes. It's a pencil-like stapes. And whenever the stapes is abnormal, usually the oval window is also dysmorphic and too tight, or it's stenotic or atretic oval window. So this I would read it as a monopod stapes with a very narrow oval window, which is likely atretic oval window. That's how I would read this as. These patients, usually even the seventh nerve is dysplastic, the course is dysplastic. There is either dehiscence or it could fall onto the old window. So that you may want to focus on that one. So monopod stapes. It's a if you pay attention to it, you'll pick it up. Many times, these patients present with conductive hearing loss, and if you don't pay attention to these subtle findings, it gets called as normal. Yeah, so you need to really, if a patient is clearly symptomatic, if you have not found an abnormality, you need to slow down. You need to really slow down and take your time. I like this image, picture. I got it from the internet. So whenever I talk about the round window and oval window, I just want to elaborate on this picture here. This is actually the cochlea. You take the cochlea and unwind it, make it straight long, and you have three lumina there. One is scala vestibuli, scala tympani, and scala media. This is in one turn of the cochlea. You have this whole thing in every turn of the cochlea, the three layers, right? And then you have the apex, that's a cupola of the cochlea, and you go all the way and then comes back. So look at this. This is the stapes. It acts like a plunger, and it pushes the sound waves, converts the air waves, mechanical thing, and transfers into the scala vestibuli, into the perilymph as a sound wave. When it pushes it, like the sound waves go through the perilymph, and then it goes all the way, all through all the turns of the cochlea, goes to the apex, and then comes back through all the other things, and comes back to the round window here, right? It's almost like this toy, which we usually used to play. That's a plunger, and that's like a tube. What happens if I seal this thing? The plunger, you can't push it if you completely seal it. So what happens if you completely fuse this round window? Can the stapes push in the sound waves? It's like a watertight compartment. So round window atresia acts as though you plug in the front end of the poplin, and then the plunger can't push in the sound waves. That's how the conductive hearing loss occurs in these patients. So round window atresia, go back to your the schematic thing, and that's normal. Let me explain you the normal. I somehow liked, most of the textbooks really keeps talking about this image for the round window. That's the round window, and that's a membrane. It's a membrane that just keeps the perilymph leaking from the inner ear into the middle ear. It's just a membrane. And this is the air in the niche, which is part of the middle ear. That's the perilymph and membrane and air. Same structures here. That's the vestibule. That's the perilymph. That's the air which you see in this area here. And there's a membrane here usually. So that's normal. And you can tell me what's the abnormality of this one. You have an obvious, very subtle but true finding, which is an atretic plate filling up the round window. And it's such a, I mean, actually, you will see it only on one cut on the right window setting. If you don't see it, you'll miss it. So round window atresia is one of the other things which are commonly missed. Okay, so that's about the old window, round window. I just want to briefly comment on the congenital cholesteatoma, which is actually not a malformation. It's actually just another, let's go back to cholesteatoma. Cholesteatomas are keratin depositions from the epithelial rest which enter the middle ear. That could occur in two ways, either a perforated tympanic membrane, or it could be surgical intervention where the surgeons dropped off some cells into the middle ear. That is an acquired cholesteatoma, right? To call it as a congenital cholesteatoma, you should not have a perforated tympanic membrane or no history of surgery. That's a primary requisite. If you have any of these two histories, you're not going to call it as a congenital cholesteatoma. Even if it looks like congenital cholesteatoma, you will just call it as a cholesteatoma in that case. Congenital cholesteatomas occur medial to the ossicular chain, somewhere near the uh, cochlear promontory, whereas the acquired ones, because it comes from extrinsic, there is the Prusak space, that's the scutum, and that the acquired cholesteatomas occurs in this area. Both the cholesteatomas erode the ossicular chain. I just wanted to bring this up because it's kind of I wanted you to know this entity. I think Sanjay, let's take a break here, and then we'll move for the thing. I just didn't want to go through this whole lecture because there's so many findings. I just wanted this to sink in. So we're going to take a 10 minutes break, and then we'll start off with the vascular anomalies.
Now we have quiz session by Dr. Sumit.
So while they're setting up the quiz session, hearing Raghu speak about the temporal bone reminds me of mammography. Dr. Rupa is here in the audience. And in some ways, the amount of attention you have to pay to detail and to small, tiny structures with mammography is very.
Okay, so we finished the external ear, finished the middle ear. Now, before we move on to the inner ear structures, let's talk about the vascular anomalies, which can straddle both, inner ear and middle ear. So, persistent stapedial artery and aberrant internal carotid arteries are the two entities which I want to talk about. So, persistent stapedial artery. So, this is the schematic representation. Let me explain this picture, take time, and then we'll look at the CT anatomy. So to orient you, this is the left temporal bone. That's the common carotid artery, a coronal view, common carotid artery, then external carotid bulb, internal carotid. It enters the skull base, that's the temporal bone here, dissected out. The internal carotid gets into the temporal bone, takes the first bend. Normally, there should not be any branches from that area. If there's a branch, that's most probably is a stapedial artery, and it takes off. The stapedial arteries are present in before birth and the involutes. And the stapedial artery goes through the middle ear in a caudocranial direction. Goes from the bottom to the top of the middle ear. And when it goes through it, it actually goes through the obturator foramen, as someone answered. So it goes through the obturator foramen. Then it hits the tegmen tympani, or the roof of the middle ear, and then enters that's the facial nerve. That's the geniculate ganglion. That's the labyrinthine segment and the tympanic segment of the facial nerve. So the stapedial artery enters the roof and then runs along the facial nerve for a short course. Actually, it is not the entire course. So can you all hear me, or yeah, okay. So it runs along the tympanic membrane for a short course somewhere from here to the genu, and then the labyrinthine segment is clean. And then it runs into the intercranial segment as medial artery. So that's the anatomy of the persistent stapedial artery. So how do these patients present? Or what is the clinical significance? For every diagnosis you make, or every findings you make, or you put it in the impression or in the description, there should be a clinical significance. Otherwise, really, there's no point in this. So what is the pulsatile? Because it's so closely attached to the stapedias, or it just causes the stapes to vibrate, then pulsatile tinnitus. And also, the stapes cannot really function normally. And you want to alert the surgeons for if they're going in for any other reasons. If they're entering the middle ear, they need to know that there is a persistent stapedial artery. That's the thing. How do we pick it up? Because many times these findings are very subtle. If you don't pay attention to those subtle findings, then you'll miss it. Here's the normal anatomy. This is an axial image of the right temporal bone, middle ear. That's a carotid canal. the bony plate covering the carotid canal should be smooth and clean. But on the left side, on this image here, which is the abnormal side thing, I'm giving the examples of the same side to compare. So these are two different patients, right? So that's a branch vessel taking off from the genium or the bend of the carotid canal. That's a stapedial artery. So almost you will see it for one or two cuts. If you don't pay attention to that on that one or two cuts, you will miss it. So whenever I come across with lesions where they're seen only on one cut, I always try to form another layer of findings where I can pick it up. That's how I approach radiology. I missed this finding on one cut. How do I pick that up on this different image or different sequence or a different thing? That's how you need to approach. So chances are, if you're looking for it, you won't miss it. But if you're not looking for it, chances are that it's only one cut, you'll miss it. Then you might see it still, it might miss it, you might miss it. The second level of, I almost call it as a net, is the finding where it enters the labyrinth tympanic segment. This enlarges this segment of the facial canal. And this segment will be normal in size. That's how it looks on the coronal image. Coronal image, that's the facial nerve, two limbs of the facial nerve. One will be enlarged, the other one will be normal in size because there is stapedial artery and also the facial nerve in that segment. That's only the nerve. To give you a sense, that's the normal side. So these two segments should be symmetric or similar in size because only facial nerve runs through that. If it is disproportionate, that's a labyrinthine segment which is smaller, only the nerve, this is nerve and the vessel, that's abnormal. Then if I see this, I go back to the bottom cut on the axial image here and then look for the stapedial artery. So you have two layers of findings, right? The one other layer would be, this is, what's that foramen? Foramen spinosum. If it is present, it's normal. If it is absent, you go back and look for persistent stapedial artery. So you have three levels of your checkpoints to really pick up the stapedial artery. Because the stapedial artery, when if it is present, it runs as the middle meningeal artery and the foramen spinosum will be absent. So three levels. Three levels. One is the branch vessel there, asymmetric facial nerve, and absent spinosum on the left side. Talk about briefly on the aberrant ICA. So again, schematic representation, and then let's look through the CT anatomy. This is a coronal image of left temporal bone. That's the common carotid artery. Branches, carotid bulb, into ECA, external carotid. And the internal carotid should have been here. That's the dotted vessel, which is absent. And when it is absent, a carotid or tympanic artery, which is a fetal circulation, takes over this function of the ICA, and that continues upwards. But that's the normal course for this artery, which should involute normally. And that runs through the inferior floor of the middle ear, and then drapes along the cochlear promontory, and then continues as the ICA. That's the aberrant ICA. Okay? So let's look to the CT anatomy. So as we saw here, this vessel should drape along the cochlear promontory. So here, let me show the normal. That's the carotid canal, which is medial to the cochlear basal turn of the cochlear promontory there. That's normal relation. But on the abnormal side, that's the internal carotid artery, goes more laterally and drapes along the basal turn of the cochlea. That's an aberrant ICA. So you need to see that relation, the aberrant ICA, you need to see it along the basal turn of the cochlea. The nearest differential for this is globus tumor. So the clinicians see it as a pulsatile red thing across the tympanic membrane. That's what the clinical history would be. But you're looking for the anatomy. And you'll be able to give them a diagnosis. And here is an MR angiogram. If I were not to provide this one, and if I were to just give this image, if you're looking for an aneurysm, say you did this angiogram for an aneurysm, this looks normal almost. Like you're looking for an aneurysm, all these twists and turns of the ICA, you'll just miss this bump. So we don't want to have these two notches on the ICA. When you're looking through the ICA, this is the aberrant ICA, the lateral curve. That's the normal, and then it goes up. You don't want to have this too much. That's the abnormal. That's the aberrant ICA on an MRI angiogram. Because many a times this is what happens. If I really want to put common things which are missed, you can put it into 4 boxes. One, when you're not suspecting a finding. If the clinician sends it as, I'm suspecting stapedial artery, then you'll find most of the times. Or if they say, at least I see a pulsatile red thing in the middle ear, you will either find a glomus, or you're looking for a glomus, or a persistent stapedial artery, or something like that. Then you'll find it. But if you're not suspecting it, you'll miss it, or commonly miss it. Second, if the findings are symmetric, and in this case, it's very symmetric, our eyes are more sensitive to pick up the symmetric findings better or asymmetric findings better. Or diffuse findings, like if the bone marrow is completely diffuse, like leukemia, lymphoma. Sometimes you miss it because it's diffusely abnormal. Symmetric finding, diffuse finding, and the second finding. You're suspecting a lesion, you found a lesion, then your attention span drops. Your chances of missing the second lesion is common. So second lesion, diffuse finding, symmetric finding, things like that, or an unexpected finding. So always pay attention to details, right? That's an abnormal aberrant ICA. This is a coronal CT, so you can actually see the aberrant ICA here, and you're seeing the ICA entering into the middle ear. That covers majority of the vascular thing. There are fewer subtle minor anomalies, but those are the 2 major ones. Inner ear anomalies. So let's talk about inner ear anomalies. The way I want to tell the residents is, think about embryology. Inner ear structure, embryology is very important. And all anomalies of the inner ear can be thought of as arrest of the Sorry about that. So as arrest or dysplasia at any stage of development, the injury could be genetic, or it could be congenital infection, or any kind of a toxic material. It could be pesticides, antibiotics, and things like that. So anything which arrests the normal development is how I think about it. There are other mechanisms also, but that's how you can easily understand the anomalies of the inner ear. So I want to explain this slide a little bit. The top row are images of abnormalities. You have various anomalies. I'm sure you've read about it, but let me explain a little bit. You have the normal here and most severe form on the left-hand side of the screen. Aplasia, common cavity anomaly, incomplete partition type 1, type 2. I'll talk about all this later, but these are all different types of dysplasias. This is a schematic picture from a embryology textbook. The normal development of inner ear, the labyrinth. It starts as a common cavity, like a small otocyst, and then kind of develops and kind of differentiates into cochlea and the vestibule, semicircular canals, and then becomes normal. And normal structure is attained at around 10 to 12 weeks. And if you notice here, this is 3 weeks. 3 weeks to 12 weeks is when the inner ear structures develop. And whenever there is an arrest at any level, it mimics or it forms different abnormalities. So if it arrests at this stage here, it's a common cavity. The cochlea and vestibule is not separated out. So it's a common cavity, and if it arrests at there, then you have the common cavity there. Then you have the incomplete partition here, and incomplete partition type 2, and then you have the normal. That's how you want to kind of look at the anomalies of the inner ear. Labyrinthine aplasia is basically a complete absence of cochlea, vestibule, semicircular canals. It looks like a dense protein capsule without any of the structures. Many of them, the closest differential, the way I look at it is the closest differential is what is this? Labyrinthitis ossificans. So how do you differentiate? Correct. So, come again, can you tell me what you said?
Cochlear promoter is not there in microsurgery because it's a
Correct. So both are right. So actually, both are right, but I'll rely more on that one because easier to find. Both are strong points, but easier to pick up stenotic or small site ICA because that's easier to get it when you're reading through this thing. So this is calcific labyrinthitis because you have a normal IAC, internal auditory canal, and completely calcified labyrinthine structures. Whereas this one you have complete absence of the inner ear structures, maybe either present or very small or stenotic internal auditory canal. That is labyrinthine aplasia. That's a normal comparison. And even the inner ear structures could be aplastic just as one segment, either just the cochlea missing or semicircular canals missing or vestibules missing. So in this patient, you have cochlea which is missing, but the vestibule, semicircular canals are all normal. Or it could be absent semicircular canals, as I mentioned. Cochlea is present, the vestibule is present, but the semicircular canals are absent. You should have seen the lateral semicircular canal there. And it is bilateral in this patient. Common cavity malformation, where there is no separation of the cochlea and the vestibule. It's a common cavity here. Maybe there's an attempted formation of the cochlea and the vestibule, vestibular aqueduct. That's complete correlation of both cochlea and the vestibule. Incomplete partition type 1 and type 2. Whenever there are two types, I just try to remember one. The other one is the other thing. Like, it's easier to remember one and then whatever is left, if there is only two types. So what I remember is this one, because this is the commoner one. The type 2 is the common one, so I remember this one. So that way, it keeps reminding me of the thing, and then you have the type 1, which is the other one. So let's discuss the type 2 and then go back to type 1. Type 2 is the most common anomaly of the inner ear. It is more popular as enlarged vestibular aqueduct. You call it as enlarged vestibular aqueduct, that's it. But if you go back to your embryology, when the vestibular aqueduct is developing, the cochlear basal turn is already formed and the second turn and the apical turn are formed. So you have every patient with vestibular aqueduct almost always will have some dysplasia of the cochlear apex or the cupula of the cochlea. If you pay attention to it, you will see it. So that is incomplete partition type 2, and it's the commonest one. The incomplete partition type 1 is there is an attempted formation of the cochlea and the vestibule, but the inner anatomy of the cochlea and the vestibule is not well formed. That is incomplete partition type 1. Did I make it simple enough for the first year or second year residents to understand? That's my intention. People are fully trained. I know you're all confident about it, but it's for the first year and second year when you want to get them onto the temporal bone, that's the difficult most portion. This is one thing I've noticed actually. To get a first year or a second year resident into temporal bone is the most difficult portion. After that, they take over. They read themselves, they get better at it. But to get them interested is the toughest portion. That's why I wanted to make it very simple. This is what I was explaining on that the picture with the pop gun. You have the three tubes going, so they are scala vestibuli media and scala tympani, and all these three tubes go through all the cochlear turns and they come back. Right? So this is one thing I want you to really know your scanner in the sense you really need to push your scanner to the limit because this is a 8-minute scan. And a very small field of view. It's like a 4 or 5 centimeter field of view. And this is the whole image of the left temporal bone. And when you take a long time and matrix size, you have to tweak it. You have to do a lot of trial runs. And once you cook it up, you can actually see the internal details of the cochlear turns. That's the basal turn. And you can actually see the membrane here, that you're seeing that structure within the basal turn there. And the scala vestibula and the scala tympani should be equal in size proportion. That's normal. In patients with incomplete partition type 2 or any other inner ear anomalies, those two tubes become disproportionate. Usually the scala vestibuli becomes enlarged, and then the scala tympani is normal. So on this abnormal side, you can actually see the scala tympani is smaller, vestibuli is very enlarged. So if you don't do a high-res, you'll not see it. I mean, if you can resolve it, you can't see it. But invariably, sometimes you can see it on the CT as a dysmorphic apical turn. That's a basal turn is very well formed, apical turn is short and dysplastic. That's how it looks on the CT. And if you do a high-res MR, I don't know if it is projecting very well on that one. Is it clear enough? Yeah. Because I really had tough time to get the image quality because once I magnified it, it became very pixelated. So pay attention to the inner details of the cochlear turns. Semicircular canal anomalies. The commonest anomaly which I see is the lateral semicircular canal, the bone island configuration. The bone island should be well formed, central in position. The lateral semicircular canal should be uniform in thickness. Abnormal side, you have the bone island kind of totally deformed, thin, narrow, that's abnormal. Or it could be drifted to the side, like that's a bone island, looks as though it's well formed, but the semicircular canal is thinned out, so it is kind of drifted off to one side. That's an anomalous lateral semicircular canal. You can do fancy reconstructions. You need to train your techs because it's really important. I mean, you can't spend so much time on every T-bones. So I've kind of taught our techs to do the oblique reconstruction to see the semicircular canals better. We have all the fancy names for it, but I just taught them how to align the two dots, and the reconstruction should be on those two dots and reconstruct the whole T-bone. That's just to keep it simple for the techs. So we're talking about dehiscence, basically uncovering or unroofing of the semicircular canal wall. So the semicircular canals open up to the dura. And that's a normal semicircular canal. Semicircular canal, that's a bony covering of the semicircular canal. On the left side, there's dehiscence of the superior semicircular canal, and it's open to the dura. So what's the problem? That's a schematic representation here. Again, we talked about it already. The oval window, the stapes pushes the sound wave. Normally, if it is all watertight, like a normal compartment, it has to run through all the turns of the cochlea to the apex and then comes back to the round window, right? And you should have only two windows for the sound waves to really go from the oval window to the round window. What happens if there is an opening here? The sound waves, instead of going preferentially through this tract, it either splits or preferentially goes into this. And the sound waves propagate into the semicircular canals, right? That's the third window phenomena, right? So it's almost like if I drill a hole into this tubing here, can you really pop this gun? You can't. Your sound waves are going elsewhere. So to keep it simple, you're looking for dehiscence. It could be congenital or acquired. Acquired could be any erosions due to cholesteatoma or it could be traumatic, post-traumatic fractures and things like that. So that's about semicircular canals. And let's move quickly to a few syndromes, which I just want to talk about it, which you make the diagnosis based on the CT anatomy. Right? Chart syndrome, BOR, branchiotorenal syndrome, and Pendert syndrome. These are less common, but this is what we see routinely in our clinical practice. So who are these patients? Actually, these patients are, in fact, you will be the first person, or as radiologists, you will be the first person to actually question Chart syndrome, because the common presentation is the nurses can't pass the nasogastric tube and they have difficulty passing. They're suspecting choanal atresia, basically. The choanal atresia is known. So they send the clinicians, and a neonatologist, they send the patient for choanal atresia. They know it. If you make a diagnosis of choanal atresia, you're not adding to the thing. What you need to tell them is their Chart association or Chart syndrome. That's the whole thing. If a patient's history is we are suspecting choanal atresia, your answer should not be choanal atresia positive. No, that's not the thing. You're trying to say, is there other problems associated with Chart syndrome, which is, it's a short acronym. Chart stands for coloboma, heart anomaly, atretic choana, mental retardation, genital abnormalities, and ear anomalies. So on a maxillofacial CT, you can see the coloboma, you can see the choanal atresia, and you can actually see the ear anomalies, three things. You can make the diagnosis of Chart syndrome based on that. So this is an image here, actually. So choanal atresia, stenotic posterior choana. Then you have anomaly of the inner ear, which is labyrinthine, actually semicircular canals are completely missing on both the ends, right? And and the posterior wall of the globes are deficient and they're colobomatous there, both the sides. So this is Char syndrome. You can actually see this colobomas on the CT also if you pay attention and get a proper reconstruction. So you're making the diagnosis. They send it for choanal atresia, but you send it back with the complete Char association. Or you may even you can say there's no features to suggest charge. That is also a significant finding, right? So that's what you need to say. What is this image showing? Sorry. Because these three are always invariably present, but that finding on that axial T2 sequence is a rare finding in Char syndrome. Sorry. Sorry. I'm sorry, I'm not able to hear you. No, spinal cord is normal. It's actually, do you mind if I take this call? They're calling me a couple of times from the, I don't know. So it is absence of the products is part of the Char syndrome, but it's an uncommon finding. You will not see it in every Char patient, but um, as the thing goes, if mind, eyes can't see what mind doesn't know. You need to know the entity, and then you'll see the finding. Because every Char syndrome, I look for the products, and I always see the product, but once in a while it's missing. So you always look for it. You need to know what the findings are to pick up the findings. If you don't know it, you won't see it. So that's absence of the product in a patient with Char syndrome. It's a rare finding. I'll skip these two findings. Let's go to the cranial nerves. So, because that's part of totally the medial aspect of the temporal bone. The common anomalies are agenesis of either seventh or eighth cranial nerve. It could be both, or it could be one of those. So normal anatomy for the first year residents. So that's the basal turn of the cochlea. So the anterior portion is here. That's the cerebellum. That's the posterior portion. This is the sagittal cut. That's the internal auditory canal. Here you'll see 4 nerves. And I've seen the residents remembering it as 7-Up and all those mnemonics, but I don't want you to remember it in that fashion. It's basically you need to remember the anatomy. The cochlea is anterior, right? So the cochlear nerve should be anterior. 7th nerve, the genu is on top of the cochlea. So anterior superior should be 7, and the cochlear, which is anterior, and it should be 7 below the 7th nerve. So that should be the cochlear nerve. And the 2 nerves posterior are vestibular, superior vestibular, inferior vestibular. So that's normal anatomy. On the abnormal side, there is internal auditory canal, which is completely blank. There is no any structures within the internal auditory canal. This is agenesis of the 7th and 8th nerve. That's an axial cut showing the 7th and 8th cranial nerves. Axial image, completely vacant or empty internal auditory canal. And these patients will have stenotic IAC also. The IAC will be smaller also. And also the singular canal and the cochlear aperture will be atretic or stenotic. That's a normal cochlear aperture, 2 millimeter in size. Whereas here, the base of the cochlea has got an atretic plate. So since the nerve is not present, the cochlear aperture is completely closed, so sensory neural hearing loss. And dehiscence of the facial nerve is another entity which I'm sure you're all familiar with. That's the 7th nerve at the oval window, and it should have a good bony covering. That's normal. When the facial nerve does not have a facial bony covering, it kind of droops and fills up that gap into the oval window. That's dehiscence of the facial nerve. That brings us to the end of the talk. Thanks.
Any questions? Well, I'm a little worried about my level of training after your lecture, because you said that Any questions? Well, I'm a little worried about my level of training after your lecture, because you said that for the first and second year residents, they should be interested in those topics. And I was very interested in those topics. So,
No, there's a lot of things I don't know on MSK
so maybe I need to restart my residency program again. But anyway, can I have the lights on?
Can I delete this?
So any questions about temporal bones?
The first
Because
one.
all of you have,
Where is all this?
as I said,
And,
70% are practicing radiologists. I'm sure all of you have read some temporal bones and had some questions at some point of time. No? Okay. You made all the findings. That's great.
Thank you, sir, for such an interesting session. I request Dr. Sanjay Vishwamitra to give token of appreciation to Dr.
Dr. Raghu he landed from US yesterday, so he's going to be fading very shortly, and he requested that he leave immediately after his lectures. So once again, thank you very much for not only spending so much time with us, but spending so much time immediately after landing from US.